Hello dear aspirants, welcome to this session of discussion of the previous year INI-CET and AIIMS questions which was asked previously in 2020. What we have done is, instead of seeing about every individual questions like INI-CET questions and AIIMS questions, what we have done is we have merged those questions together and we have categorized them into several different set of questions based on the topics which we have read in pharmacology. Like in general pharmacology, what are the questions which has been asked in last year INI-CET and AIIMS? Similarly for ANS, for CVS, for CNS, for antibiotics, and every individual topics we are going to read about. Before going further, let's talk about the important areas where questions has been mostly targeted on based on the last previous year. To say around 2 to 3 years of questions, certain areas are constantly been targeted on for INI-CET exams, which includes in general pharmacology. In general pharmacology, we can see the drug administration. Drug administration includes the route of administration, like it might be peroral or sublingual or transdermal. Most importantly, the sublingual route of administration and parietal route of administration is currently being targeted on. Next one, we have receptors, the receptor related pharmacology like extracellular receptors, what is the transmembrane receptors and intracellular receptors. Prodrug concept, recently it has been asked, to say compulsory one question is being asked either directly or by indirect way. The next one, we have autonomic nervous system. In autonomic nervous system, again previous year the questions was targeted based on muscarinic receptors. Adrenaline dilution, a must ask question, especially in AIIMS. Why? Because every year a question will be asked directly from adrenaline or from adrenaline dilution or the use of adrenaline or the route of administration of adrenaline. Anything related to adrenaline, the question is going to be asked. Myasthenia gravis, last year a question was asked. For autocoids and analgesics, migraine question has been recurrently asked, and last year itself we have got 2 questions. In INI-CET and AIIMS, we have got 2 questions especially from NSAID itself. Respiratory system, we have the default bronchial asthma. In hormones, we have osteoporosis, diabetes, OCP and thyroid. These 4 are the primary targets as per the INI-CET and AIIMS is concerned. In CNS, we have alcohol, most importantly because NEMANS is getting involved. There will be getting lots of questions, especially from central nervous system. Among central nervous system, the antidepressants, please note this, an important area. The antidepressants, the anti-epileptics and lithium. These 3 are the most important one among central nervous system where questions are recurrently being asked. Also, we have opioids too. The other topics includes cardiovascular system. In cardiovascular system, we have hypertension, angina, the most commonly asked areas. Arrhythmia questions mostly is being asked not from INI-CET, it is mostly being asked from NEET PG. So please pay more concentration on hypertension and angina, especially treatment for myocardial infarction. Blood, GIT and renal system, dyslipidemia, fibrinolysis and hematinics. Even recently we can include anticoagulants too. We can include anticoagulants too along in this because of the recent surge in the use of anticoagulants COVID season. We have lots of questions from clinical pharmacology like regarding therapeutic drug monitoring, regarding the drug action. All these questions is getting asked from clinical pharmacology too. Among antibiotics, we have drug allergy, antihelminthics and most importantly TB and COVID. 2 questions has been asked from each of these topics in the last year INI-CET exams. Also HIV and antifungal drugs. Anti-cancer and miscellaneous, only 1 or 2 direct questions is getting asked, especially targeting the adverse effects and drug of choice. As per anti-cancer drugs is concerned, we have to target more on the adverse effects of drugs and the drug of choice of individual cancers. Is that clear, guys? Now we'll move on to the first question which has been asked from general pharmacology. We are going to see about the questions which is being asked from general pharmacology in the last year INI-CET which has happened in November and AIIMS which has happened in June 2020. The first question includes, all of the following are advantages of entry-coated tablets except. The question is an exception. First of all, let's see about what is an entry-coated tablet. Entry-coated tablet was actually designed by, because consider here is where your gastrointestinal tract is. Here is where your gastrointestinal tract is and here is where your intestines is. Whenever a drug is being administered, the drug gains entry into the stomach. And because of an irritant property of the drug, this drug is going to cause irritation of the walls of the stomach. It is going to cause irritation of the walls of the stomach. The first important factor. The next one, certain drugs is going to get broken down because of acids which is there on the stomach. Because of the acidic pH, certain drugs is going to be broken down. Acid lability or acid labile drugs. And the third important feature is, these drugs normally, I am not talking about entry-coated tablets, normally when we administer, the absorption of the drug is going to be maximum in the intestines. So the primary concept is we have to make sure that this drug is going to reach the intestine up to the maximum, so the absorption is going to be proportional. Is that clear? So in order to increase the absorption rate from the intestine. Now to increase the absorption rate from the intestine. So three major factors are involved why we give whenever we administer a normal tablet to a patient. Now what happens is, in order to prevent this irritation concept, in order to prevent the gastrointestinal irritation, in order to prevent the acidic breakdown of the drug, in order to increase the absorption of the drug in the intestines, we make sure that we cover the drug with an entry-coated forms. These entry-coated tablets are used which protects acid labile drugs from gastric pH, increases the absorption of drugs that are preferentially absorbed distal to the stomach. That's what we have already explained, and it protects stomach from the irritant drugs. What about half-life? See guys, this is the answer for this question. The half-life is the answer for this question. Why is it? Because the half-life is based on once the drug is getting absorbed from the intestine, the drug gains entry into the blood. Now how much time the drug is spending in the blood? Based on that is what the half-life is getting calculated. How the drug is fastly metabolized, how the drug is fastly excreted out. That is the concept behind half-life. Whereas the coating the tablet with this enteric layers is usually to increase the rate of absorption. It is not dependent on half-life. Half-life is not dependent on the absorption concept. So this is the answer for it, because the question is an exception. It increases the half-life of the drug is actually not related to the absorption concept which we have explained till now. Now we go to the next question. Which of the following drugs acts through intracellular receptors? Intracellular receptors. So we have thyroxine, glucagon, epinephrine and parathyroid hormone. We have to know an important concept, buddies. If a drug is going to be very much shorter, smaller in size, if a drug is smaller in size and if a drug is larger in size, we have two different concepts, a smaller drug or a larger drug. We can also classify it as lipid soluble and water soluble agent. Consider this drug is a smaller molecule and it is a lipid soluble molecule, whereas this one is a larger molecule and it is a water soluble molecule. Now consider we have the cell over here. Consider we have the cell over here, and inside this where the nucleus is. We have the nucleus over here. So the function of these two different substances is to gain entry into the nucleus and activate the particular part of the nucleic acid, so that the further protein synthesis is going to be either increased or decreased. Now if this drug is going to be smaller in size, if it is a smaller molecule or it is a lipid soluble molecule, it can easily gain entry into the cell and it can bind with two different types of receptors. Receptors which are there on the cytoplasm or which are there on the nucleus. Receptors which are there on the cytoplasm or which are there on the nucleus. So two different areas might be there for lipid soluble molecule or a smaller molecule to bind and produce the action. But that is not going to be seen with a larger molecule. Why is it? Because this larger molecule and also which are water soluble molecule are not allowed to enter. Is because it is water soluble, it is not going to cross the membrane. It is going to be deflected out. It is going to be deflected out. So, but we need to gather the information from the larger molecule and send it towards the nucleus. So, we either increase the protein synthesis or decrease the protein synthesis. So, now what happens? We have the larger molecule which is waiting outside. So, here is where the basic function is. What we do is, what the nature did is, it designed a receptor which is there on the membranes, it designed a receptor which is there on the cell membrane. It receives those impulses, and those impulses in turn are going to be sent into the nucleus. The larger molecule need not come inside the cell, it can remain outside. The receptors will gather the impulses from the molecule and it will send it back into the nucleus, so the further process is going to happen. Whereas smaller molecules or lipid soluble molecules, no need to worry, this drug directly gains entry into the cell and binds with its own receptor. So simply put, if any of the drug is larger or it is a water soluble molecule, we have transmembrane receptor. Or if a molecule is smaller or if it is lipid soluble, we have intracellular receptor. Among these intracellular receptors, as we've already explained, it might be of two different types. Is that right? And what are those two different types, buddies? Cytoplasmic and nuclear. Cytoplasmic receptors and nuclear receptors. And what are the different molecules or which are the drugs which are going to bind with cytoplasmic receptors and nuclear receptors? Nuclear receptors, we have thyroxine T3, T4, vitamin D, retinoic acid. retinoic acid. All these molecules is going to bind with nuclear receptors. We have several different types of nuclear receptors like retinoid X receptor, PPAR alpha or PPAR gamma, pregnane X receptor, constitution X receptor, constitutive X receptor. These are the different types of nuclear receptors, but the molecules which is going to bind with the nuclear receptors is going to be T3, T4, vitamin D and retinoic acid. What about cytoplasmic receptors? We have glucocorticoids, the corticosteroids, glucocorticoids, mineralocorticoids, and also the sex hormones which includes androgen. Sex hormone which includes androgen. All these molecules tend to have cytoplasmic receptors, whereas T3, T4, vitamin D and retinoic acid tend to have nuclear receptors. Now, what is the question? Coming back to the question again, which of the following drugs acts through intracellular receptor? So the action, the first point itself is there. The answer is thyroxine, guys. Glucagon, epinephrine and parathyroid hormone, all these tend to bind with a transmembrane receptor. Transmembrane receptor, especially it is a G protein coupled receptor. Glucagon, epinephrine and parathyroid hormone tend to bind with a G protein coupled receptor. Is it a GS or is it a GQ receptor? It is based on the type of individual areas. Glucagon, we have GS receptor, no need to worry. But for epinephrine, it might bind with either alpha 1 or alpha 2 or beta 1 or beta 2. Whereas alpha 1 is a GQ coupled receptor, beta receptors are all GS coupled receptors. Fantastic. So this is the basis of the intracellular receptor, most important concept as per the INI-CET exams is concerned, guys. Moving on to the next question, which of the following is not a prodrug? First of all, what is a prodrug, guys? Prodrug is nothing but, consider we have an active form of drug. We have an active form of drug. We administer the drug to the human body. We administer the drug to the human body. But this drug tends to be broken down fast. It's going to be converted to inactive metabolites at a faster rate. It is going to be converted to inactive metabolites at the faster rate because of the enzymes which is there on the liver, because of microsomal enzymes or the enzymes which is there on the GIT. Now what do we do? In order to prevent that, what we do is we give a prodrug. We give a prodrug. This prodrug again is going to be administered to the human body. It's going to be administered to the human body. This prodrug is going to be converted to the active form inside the liver, following which the drug is going to gain entry into the blood. Now after it is reaching the blood, after it has produced the action, again when the active drug is going to come back into the liver, it is going to get metabolized. Which means we are trying to skip the first and the foremost important step of the inactivation of the active drug or breakdown of the active drug. That is the concept behind usage of a prodrug. Why do we use a prodrug? That is the concept behind it. But here, 4 different drugs, guys. We have 5-fluorouracil, primidone, proguanil and sulindac. Please note that primidone is not a prodrug. Why is it? Because primidone itself is an active drug. Primidone itself is an active drug. It is going to be converted to an active metabolite. It is going to be converted to an active metabolite. It is going to be converted to an active metabolite, which means, for example, we have cyclophosphamide. Cyclophosphamide can be converted again to an active metabolite called as acrolein. Paracetamol can be converted to a highly reactive metabolite called N-acetyl parabenzoquinone imine. Right? So here, primidone is not a prodrug. That is the answer for this question, guys. That's it about. We have seen about 3 questions in general pharmacology. These questions were asked previously in INI-CET and also one of the other AIIMS exams which was conducted before that. Moving on to the next one, autonomic nervous system. In autonomic nervous system, the first question is, which of the following action is expected on stimulation of muscarinic receptors? This is what we have already explained, guys. Muscarinic receptor stimulation and the concept behind it. Erection, ejaculation, increased contraction of cardiac muscles and bronchodilation. We have already explained that in the regular sessions of pharmacology which we have done in DocTutorials. The concept is erection happens due to parasympathetic system, whereas ejaculation happens due to sympathetic system. Erection happens due to parasympathetic system and ejaculation happens due to sympathetic system. The most important one which we have recurrently been explaining that. So that is the concept behind it. The answer for this question is what? Erection is the answer. Which of the following is going to be seen on stimulation of muscarinic receptors? Erection is going to be seen. Ejaculation is going to be seen with sympathetic autonomic nervous system stimulation. That is going to be ejaculation. Increased contraction of cardiac muscles. Cardiac muscles increased contraction, it is not possible. Why is it? Because the muscarinic receptors are of 3 different types. The muscarinic receptors are of 3 different types, M1, M2 and M3. We also have M3 and M4, but it is not that much important in human beings. It is very much least purposeful in human beings, at least for this generation. I don't know about the future. There might be some mutations which might be happening in the future, but nowadays M4 and M5 is not of that much importance. Out of this, M2 is the receptor which is there in heart. So what are the types of these receptors? We have already seen M1, M2, M3, M4 and M5, right? All these receptors are G protein coupled receptors, guys. All these receptors are G protein coupled receptors. What's the type of these individual receptors? It can be remembered with the mnemonic QIQIQ, which means M1 is a GQ receptor, M2 is a GI receptor, M3, M4 are GQ and GKI respectively, and M5 also is a GQ receptor. Out of this, we have seen that M2 is a GI receptor, is that right? M2 is a GI receptor, which means here is where a GI receptor is going to be there. If GI receptor is going to be there in heart, it is going to cause inhibitory responses, is that right? It is going to cause inhibitory responses. What are the different inhibitory responses which we can see? Usually we have three different tropies, guys, right? Inotropy, chronotropy and dromotropy. We have inotropy, chronotropy and dromotropy. Out of this, M2 receptor, if it is getting activated, it tends to produce negative chronotropic effect, negative dromotropic effect, and it has got nil effect on the inotropy. Why is it? Because inotropy is, we are going to explain the contraction of the ventricles. Chronotropy is nothing but heart rate. Inotropy means ventricular contraction. Chronotropy means heart rate decision. Heart rate is decided by the SA node which is there on the atrium. It is dependent on the atrial responses. Dromotropy again is going to be conduction of impulse from the atrium towards the ventricles. Again, atrium is involved in it. Whereas inotropy is going to be involving ventricles. Please note that ventricles does not contain any muscarinic receptor. Only the atrium will be containing muscarinic receptors. So there is just going to be a negative chronotropy and negative dromotropic effect, that the inotropic effect is going to be nil in nature. So in this question, we have seen increased contraction of cardiac muscles, which is practically impossible with this muscarinic receptors because it has got nil action on it. Bronchodilation, no guys. Why is it? Because M3 receptor is going to be there in bronchus. M3 receptor is there in bronchus. And we have already seen M3 receptor is what type of receptor, guys? It's a GQ receptors. If you have went through the GP regularly, we would have known that GQ receptor is nothing but is going to produce smooth muscle contraction, right? It's going to produce smooth muscle contraction. So bronchus is going to be contracted. There's going to be bronchoconstriction with M3 receptors. That is the reason why anticholinergic drug is useful in treatment of bronchial asthma. It is going to produce bronchodilation. More than bronchial asthma, it can be better used in COPD than bronchial asthma, a classical feature of anticholinergic agents. So which of the following action is expected on stimulation of muscarinic receptors? Erection can be expected, ejaculation is expected, is seen only with sympathetic autonomic nervous system. Moving on to the next question in autonomic nervous system. Match the dilution of adrenaline with its use. Again, adrenaline and most important concept in INI-CET exams. Adrenaline, we have three different dilutions and three different uses. We have to match both of these things. Please remember this particular concept, guys. Adrenaline dilution can be seen with 1 in 10,000, 1 in 1,000, 1 in 100. Three major dilutions are there. 1 in 10,000, 1 in 1,000 and 1 in 100. Out of this, which one do you think is going to be more dilute and which one do you think is going to be more concentrated, guys? Which one is more dilute and which one is more concentrated? Yeah, 1 in 10,000 is going to be more dilute, right? 1 gram is dissolved in 10,000 ml of water. That's called as 1 in 10,000. 1 in 100 means 1 gram is dissolved in 100 ml of water. So 1 in 100 is going to be more concentrated than 1 in 10,000. If it is more concentrated, it has to be administered via inhalational route. Why is it? Because we have many different routes of administration, guys. Intramuscular, intravenous, even subcutaneous. We have intracardiac and we have inhalational. Out of all these three, which route of administration tend to lose a lot of the adrenaline? Because if I give adrenaline via inhalational route, only certain amount of drug is going to reach the body, the remaining is going to be exhaled out. And certain amount only is going to get absorbed into the blood. So that's the reason why we choose a more concentrated form of adrenaline for inhalational route of therapy. 1 in 100 is for inhalational therapy, inhalational route. And 1 in 1,000 is for intramuscular or subcutaneous route. Intramuscular or subcutaneous route, we opt for 1 in 1000. Please remember that in case of shock, we don't administer adrenaline via subcutaneous route because there is going to be peripheral vasoconstriction. We have to administer it via intramuscular route, only then the blood supply is going to be concentrated enough. We all know that in case of shock, what is going to happen? There is going to be redistribution of blood supply from the peripheries. So all the cutaneous blood supplies is going to be contracted and all the blood supplies is going to be redirected to the individual systems. So it includes muscle. The better route for administration of adrenaline in terms of emergency, in terms of shock, is intramuscular route. 1 in 10,000 we can administer it by directly into the IV because none of the drug is going to get wasted. So we are going to administer all the adrenaline into the body. So that's why we dilute the adrenaline up to the maximum and then we administer the drug. Intravenous or even intracardiac. Intravenous, intracardiac, both of these routes we have to administer it as 1 in 10,000 dilution. Apart from this, we have one more dilution, and that is adrenaline when it is given along with lignocaine or when it is given along with a local anesthetic agent. The concentration or the dilution of adrenaline when it is given along with a local anesthetic agent is 1 in 50,000 to 1 in 2 lakhs. 1 in 50,000 to 1 in 2 lakhs is the normal dilution with which we administer adrenaline with lignocaine. And why do we administer adrenaline with lignocaine? In order to produce a bloodless field for surgery, in order to increase the efficacy of local anesthetic agents, in order to prevent the adverse effects of local anesthetic agents, because blood vessels are constricted. The drug is not going to get absorbed. The local anesthetic agent will remain in that area and the patient will be having long lasting action. If local anesthetic agents is getting absorbed into the blood, it might cause systemic adverse effects like arrhythmia. Is that clear? These are the different dilutions, guys. So now we are going to match it. And what are the different concepts here? 1 in 1000 is for intramuscular route in anaphylaxis, as we have already explained. Intramuscular route in anaphylaxis. 1 in 10,000 is for intravenous route in cardiac arrest. 1 in 1 lakh is when it is administered with lignocaine. This is the match for that. So A2, B1 and C3 is the match, is the correct answer for this question. Moving on to the next question. In autonomic nervous system, all of the following drugs can worsen myasthenia gravis except lignocaine, digene, phenytoin, meropenem. So many got into a confusion. What is the digene, right? So don't get confused. It's actually it shouldn't be used in terms of in terms of a national examination. We shouldn't use trade names, but they have used this trade name. But digene is nothing but digene contains aluminum hydroxide and magnesium hydroxide. Digene contains aluminum and magnesium as the active product. It is one of the over-the-counter syrup which can be used. So we have seen lignocaine, digene, phenytoin and meropenem. What is the answer behind it? So drugs which might induce or which might worsen myasthenia gravis. Drugs which might induce or worsen myasthenia gravis. Many different set of drugs are there. All these can be remembered with the mnemonic. For Amitabh's MCQ, remember beta has BP. This is the mnemonic to remember the drugs which might worsen myasthenia gravis. So for Amitabh's MCQ, from the name Amitabh's MCQ, we can note that this mnemonic is to remember the drugs which might worsen myasthenia gravis. And from that, we are going to talk up certain drugs too. AMI is for aminoglycosides. AMI is for aminoglycosides. M is for morphine and magnesium. C is for curare drugs, your tubocurarine and also we have cane drugs. Cane drugs is nothing but your local anesthetic agents, lignocaine, bupivacaine, all the cane drugs. Q is for quinine, quinidine, quinolones. Even your fluoroquinolone also has got a milder effect in worsening myasthenia gravis. Beta is for beta blockers and B is for botulinum toxin and P is for penicillamine. P is for penicillamine. So these are the different drugs which might worsen myasthenia gravis. So the concept is simpler, guys. Actually, the concept behind the worsening of this myasthenia gravis concept is, consider here is where consider this is your nerves, right? This is your neurons, and inside the neurons already we all know that whenever a neuron is at rest, what is going to happen inside? It's always negative and acidic. a resting neuron, inside it's always negative and acidic. So the negative, normally the charge is in negative, but we have a receptor here, and that receptor is a sodium channel. We have a channel over here, and that channel is a sodium channel. How this neurons is going to get excited? By influx of sodium ions. When there is opening of this sodium channels, there is going to be influx of sodium ions. Because of the influx of sodium ions, the negative will become positive, and the impulse will be transmitted from this end towards this end. When the impulse comes to the next neuronal cell, there is going to be opening of this sodium channel, and the sodium gains entry into the cell. And the sodium gains entry into the cell, the negatives will become positive, and the impulse will be transmitted towards the next cell. This is how the impulse is going to get transmitted. Now what happens whenever you administer a similar concept? This is what happens whenever it is in the neuronal cell. What if this is a muscular cell? What if this is a muscular cell? Here is where your neurons is, right? This is your neuromuscular junction, NMJ. This is your neuromuscular junction. From the neuromuscular junction, normally what happens? There is going to be release of acetylcholine. This acetylcholine is going to bind with its own receptor. This is an ionic channel. We have an ionic channel on the surface of the neuromuscular junction, and that receptor is NM receptor. So when acetylcholine comes and binds with it, we need two acetylcholine molecules to bind with this receptor to cause activation of it. For opening of the nicotinic receptor, we need two acetylcholine molecules. For opening of muscarinic receptors, we need one acetylcholine molecule. So whenever the acetylcholine comes and binds with this NM receptor, there is going to be a conformational change on the receptor. There is going to be opening of the channel. Because of the opening of the channel, there is going to be influx of sodium ions. Whenever there is influx of sodium ions, the negative charges will become positive inside the cells. So now the cell has got depolarized. Once the cell has got depolarized, what's the next step, guys? There is going to be opening of a calcium channel. There is going to be opening of a calcium channel. Because of the opening of calcium channel, there is influx of calcium. Already we have sarcoplasmic reticulum, which is stored with calcium with its own ryanodine receptor. We have the ryanodine receptor on the surface. Now this calcium which has gained entry is going to bind with the ryanodine receptor. Because of the binding of calcium with ryanodine receptor, there is going to be further release of all the stored calcium into the cell. There is going to be further release of all the stored calcium into the cell, which further is going to bind with the actin and myosin filaments, and thereby there is going to cause contraction of the skeletal muscle. So the contraction of skeletal muscle is dependent on the calcium-induced calcium release, which is happening because of the binding of calcium with the ryanodine receptor. So all these things is happening. Why? Because of a particular binding of acetylcholine with its own receptor. Because of the influx of sodium ions. If the cell is not getting depolarized, there is no chances of influx of calcium ions. So all these things is dependent on the influx of sodium ions. Now what if we administer a positive charge molecule to the patient? So what if we administer a positive charge molecule to this particular patient? A positive charge molecule, if it is getting administered, we have lots of positive charges which are getting accumulated outside. And these positive charges will compete with the influx of sodium ions. These positive charges will compete with the influx of sodium ions. So not only that, we have lots of two positive charges which is been roaming outside too. We have two positive charges too. This will compete with the calcium ions from getting entry into the cell. So any single positive molecule or a two positive charge molecule is going to be preventing the skeletal muscle from landing up in contraction, and that is the concept behind myasthenia gravis. What is myasthenia gravis? Already there is a destruction of the NM receptors which is there in the body because of autoantibodies. Now what happens? Because of the administration of a positive charge or a two positive charge molecule, it is going to further worsen the condition, and that's why we can see lots of single positive or a two positive charge molecules. Example, we have magnesium, aminoglycosides, which is a single positive charge molecule. These drugs are going to be single positive charge, and that's why the answer for this question is lignocaine, yes. Digene, which contains magnesium, so yes. Phenytoin, yes, it also is going to be involved in the worsening of myasthenia gravis, but meropenem, no, it is not going to be involved in it. So the answer for this question is what? Option 4 only, and that is the answer for this question, right? Why? Because phenytoin is going to be given along with sodium, phenytoin sodium. I hope you remember the name of this drug. So phenytoin sodium will compete with sodium for its influx along the sodium channel. So phenytoin also is going to worsen the myasthenia gravis. That's it about the questions from autonomic nervous system, guys. Moving on to the next one, autocoids and analgesics. A patient with no history of angina or myocardial infarction angina with no history of angina or myocardial infarction, presents with new onset chest pain after taking a drug for migraine headache. The possible implicated drug mechanism of the drug is, what's the mechanism of that drug? See, migraine, the drugs which is used for migraine, what is actually migraine? Migraine is caused because of vasodilatation. Migraine is caused because of vasodilatation. So, any drug which is going to induce vasoconstriction is going to be involved in the treatment of migraine. Treatment of migraine is going to be involved in induction or production of vasoconstriction. The classical drug, that is triptans. The classical drug, that is triptans, what is the mechanism of action of triptans? It tend to behave as 5-HT analog agents or 5-HT agonistic agents. Behaves as a 5-HT agonistic agent. As it is behaving as a 5-HT agonistic agent, that is how it is going to produce vasoconstriction. That is how it is going to be useful in treatment of migraine. If it is inducing vasoconstriction, and it might cause vasoconstriction even in the cardiac muscles too, and because of the coronary artery vasoconstriction, the patient might land up in chest pain. Is that clear? This is the mechanism behind how a migraine drug can induce development of myocardial infarction, or coronary artery vasospasm also can be seen with those. The next question, read the following statements regarding the use of given drugs and choose the correct option. Morphine is used for the treatment of pulmonary edema. Indomethacin can be used to treat headache. Aspirin is used to treat dyspepsia or gastric ulcer. Pethidine can be used in the treatment of biliary colic. Which of the following is going to be true? That is the question behind. So, we all know that morphine can be used in treatment of pulmonary edema. Yes, that is the drug of choice which is used in treatment. Why is this? Because morphine tend to redistribute blood from the pulmonary blood vessels towards systemic blood vessels. Right? So, that's the reason why we can use morphine, an opioid which can be used for the treatment of pulmonary edema. Even though morphine is associated with the respiratory depression, we can use it is contraindicated in other respiratory depressive disorders. Except for pulmonary edema, we have to administer morphine. The next one, we have indomethacin. Indomethacin, yes, it can be used for the treatment of headache. It can be used for intense headache. For severe headache, we can use indomethacin. It has got many different mechanisms apart from its NSAID property, but it can be used for headache. Even though it is not the drug of choice, it can be used for headache. Currently, indomethacin is being used for the treatment of acute gout too. Aspirin is used for the treatment of dyspepsia. No, aspirin tend to induce development of gastric ulcer. Aspirin is an NSAID. This NSAID aspirin. This aspirin is a non-competitive irreversible inhibitor of cyclooxygenase enzymes. Non-competitive irreversible inhibitor of cyclooxygenase enzymes. Aspirin might induce development of gastric ulcer symptoms, also might induce development of bronchoconstriction. There is a concept called as aspirin-induced bronchial asthma too. So, this drug is a wrong statement. This statement is a wrong statement. This statement is true. This statement is true. Pethidine can be used in treatment of biliary colic. This statement also is a true statement because pethidine tend to produce relaxation of the smooth muscles, so it can be used for the treatment of biliary colic. Morphine is going to be contraindicated. Morphine cannot be used for biliary colic, whereas pethidine can be used for biliary colic. So, out of these three, which are the correct options, guys? We have option 1, option 2 and option 4. 1, 2 and 4 are correct statements. So, option D here, statements 1, 2 and 4 are the correct statement, is the answer for this question. Moving on to the next question. A patient presents with sudden severe pain in first metatarsophalangeal joint. From this itself, we can find out that this is the case of acute gout. Anyhow, we'll just go further. Negatively, bifidus crystals were seen in joint fluid. It's a confirmatory, it's a gold standard. Which of the following statements regarding drug usage in this patient is correct? So, this patient is acute gout. This patient is in acute gout. So, what is the treatment options which has been given? That's the we have to find out the correct statement here. Aspirin should be used as it is the best pain relieving NSAID. It is a best pain relieving NSAID. It tends to decrease pain a lot, but it is not going to be used for gout, guys, because aspirin, when given at low doses, it has got low dose, it can be given at medium dose and it can be given at high doses. When given at low doses, it tend to increase the serum uric acid levels. It tend to worsen gout. It tend to worsen the levels. It tend to worsen hyperuricemia. Whereas when given at high doses, it tend to decrease the uric acid levels. The opposite activity can be seen. In medium doses, it has got meager activity on the level of uric acid levels. But aspirin, so from this what we have learnt is aspirin can be given at high doses and it can be given for gout, right? But aspirin At high doses, majority of the patients is not going to tolerate it because of the adverse effects associated with aspirin. So usually we administer either low dose or a medium dose aspirin, and that low dose and medium dose is going to worsen the gout symptoms. So aspirin is not going to be given in terms of acute gout. The patient is in acute gout, it is not going to work out. So this statement is a false statement. Aspirin should not be used as it inhibits the secretion of uric acid in tubules. Yeah, so thereby it is going to increase the uric acid levels. This is what we have explained till now. Diclofenac is used as it is concentrated in joint spaces. That is the classical feature of diclofenac, guys. Diclofenac being an acidic drug, diclofenac sodium, right? If any drug name is going to end with a positive charged molecule like phentoin sodium, or if the molecule's name is ending with calcium or magnesium or aluminium or potassium, these are positive charged molecules. Any drug molecule's name, if it is ending with the positive charged molecule, it means that that drug is an acidic drug. And the contrary, if any drug molecule is ending with a name which is a negative charged molecule like chloride or sulfate or bromide or iodide, all these are negative charged molecules. If any drug molecule is ending with the names of these ions, those drugs molecules are basic in nature. Diclofenac sodium, as it is an acidic drug, tend to get concentrated in the inflamed areas, especially in the joint spaces. So it can be used better to, because it is going to be concentrated in joint spaces, it can be used better for the treatment of acute gout. Indomethacin is used since it has good pain relieving action. Yes, it is also a true statement. Indomethacin also can be used among the NSAIDs. Indomethacin is not used because it can cause severe headache. No, it's a false statement. We have just now seen in the previous question that indomethacin can be used for the treatment of severe headache. Indomethacin is not going to produce severe headache. So in this condition, what are the different correct statements, guys? 2, 3 and 4 are correct statements. So option B is the answer for this question. Is that clear? Please remember that in case of acute gout, consider we have an option. In this option, they have given allopurinol or febuxostat or even lesinurad or even the newer rasburicase or pegloticase. Please don't go for that. Why is it? Because this case is a typical sudden severe pain. The patient is a typical acute gout. For acute gout, this kind of uricose uric drugs or xanthine oxidase inhibitors are not going to be recommended, because for acute gout, the drug of choice is NSAID. First, relieve the pain is because of inflammation. If the patient is not responding to NSAID, that is where the option is not there. If the patient is not responding to NSAID, not responding to indomethacin or diclofenac or piroxicam or any of the other nimesulide, any of the drugs, the patient is not responding. What's the next step in management? We can opt for steroids. So steroids is going to be used in terms of pain which are unresponsive to NSAID. Colchicine also can be given for acute gout, but based on the adverse effects, we don't normally use. Colchicine, we know colchicine is a drug which can be used only for acute gout, guys, because it has got only anti-inflammatory property. It does not decrease the uric acid levels. Colchicine is going to be having only anti-inflammatory property. It can be used only for acute gout. It is not used for chronic gout, and most important adverse effect is diarrhea. The diarrhea is very severe that we stopped using colchicine and we replaced it with NSAID. Is that clear? That's it about autocoils, guys. Moving on to the next question here from the respiratory system, which has been asked last year in INICET and also in AIIMS. Which of the following is most common drawback with the use of the device shown in the diagram? So what is this device, guys? Majority of you would have seen this or would have used this, but you would have to know the name of this. This is PMDI. PMDI means pressurized meter dose inhaler. Pressurized meter dose inhaler is the name of this one. Pressurized meter dose inhaler, the concept of this is where the canister is going to be loaded up, and once we press this button, the drug is going to be sprayed out from this area. This is your mouthpiece. This is your mouthpiece. The drug is going to be sprayed out and the drug is going to move into the lungs. But we have an issue here, and that issue is this molecule, this canister which is being loaded might be containing larger molecules and also might be containing smaller molecules. Larger molecules and also might be containing smaller molecules. Now what happens is, these smaller molecules, no problem at all, it will easily reach the lungs because these are smaller in size, it can easily reach the lungs. What about these larger molecules? These larger molecules is not going to reach the lungs, so instead these larger molecules in turn is going to be deposited in the pharynx. These larger molecules in turn is going to be deposited in the pharynx. If it is a beta blocker, no problem at all, but if it is a steroid, But if it is a steroid, what is going to happen? It is going to get deposited on the posterior part of the nasopharynx, and as it is getting binded with the nasopharynx, there is going to be induction of immunosuppression over there. Because of immunosuppression, the patient might be having hoarseness of voice. The patient might be having hoarseness of voice, and there might be oropharyngeal candidiasis too. And there might be development of oropharyngeal candidiasis too. In order to prevent that, what do we do? Usually what we do is, if a patient is taking pressurized metered dose inhaler for steroid, and after taking, the drug might be getting deposited in the oropharynx, usually we advise the patient to gargle. So if you gargle with the warm water, the drug is going to be spit out. It's not a major issue, but in order to prevent the further process, we can, so how do we prevent it? We can go for gargling, or we can also use spacers. Spacers is going to prevent the deposition of these larger molecules in the pharynx. The larger molecules will be trapped in those spaces, and only smaller molecules is going to move and it gains entry into the lungs. So the major drawback with the usage of this drug is what? It is not portable. No, it is easily portable. We cannot provide multiple doses. No, I can give multiple doses even at emergency times also. Risk of bacterial contamination is high. No, this canister is clearly made of certain substances, and it is clearly cleaned off. There is no chances of bacterial infections. Drug deposition in oropharynx, that is the most common drawback of the use of this drug. So this is the answer for this question. Is that clear? Moving on to the next topic, hormones. Which of the following drug used in osteoporosis is a bone forming agent? Bisphosphonates, teriparatide, calcitonin, raloxifene. Please note that the question is clear. They were asking about bone forming agents. They didn't ask for drugs which might prevent osteoporosis. Both are different, guys, right? It's the most commonly asked one, no need to worry. So the treatment options, we have two different ones. Drugs which might block bone resorption. Drugs which might induce new bone formation. Drugs which might block or inhibit bone resorption, or which might induce new bone formation. New bone formation can be induced with teriparatide, abaloparatide, and also we have the newer monoclonal antibody romosozumab. These are the three drugs which might induce development of new bone formations. What about drugs which might inhibit bone resorption? Both concepts are different, guys. It prevents damage, it induces new bone formation. All the drugs can be remembered with the mnemonic SET BCD. SET BCD is the mnemonic to remember the drugs which might prevent bone resorption. S is for selective estrogen receptor modulators. E is for estrogen. T is for thiazide diuretics. B is for bisphosphonates. C is for calcium and calcitonin. And D is for vitamin D3. So all this, also we have the newer drug, that is denosumab. It is also a monoclonal antibody. So romosozumab and denosumab, these are the two different monoclonal antibodies which can be used for the treatment of osteoporosis. Romosozumab is going to induce new bone formation. Denosumab will prevent bone resorption. Please remember that if the drug name contains os, it is used for osteoporosis, right? It's the key for remembering the monoclonal antibodies used for osteoporosis. So here, based on this question, which of the following drugs is used in osteoporosis is bone forming agent? The answer here is what, guys? Teriparatide is the answer for this question, and also we have the derivative of teriparatide, that is abaloparatide. We have the next one in hormones. A 70-year-old patient has diabetes and hypertension. See, he or she is old age. He presents with late stage chronic kidney disease, CKD. The patient is a known case of CKD too. Which of the following anti-diabetic drugs require least dose modification in renal disease? For this, we have to know the questions. The options here is sitagliptin, vildagliptin, linagliptin, and saxagliptin. So all these drugs come under the classification of dipeptidyl peptidase type 4 inhibitors, DPP type 4 inhibitors. All these drugs will come under that classification. So the question is clear. For the treatment of diabetes, we have to opt for DPP4 inhibitor. Among DPP4 inhibitor, which drug can be safely prescribed in case of renal failure? We have to know one important thing, that linagliptin is the only drug which is excreted via bile. It has got very minimal plasma level changes in renal failure. very minimal plasma concentration level changes in renal failure. So linagliptin is the only sitagliptin or only DPP4 inhibitors which can be used in case of a chronic kidney disease. It's a very important question, guys, please don't forget. And also there is no need for dose reduction even if the patient lands up in CKD. If a patient is on sitagliptin, consider if a patient is on sitagliptin or vildagliptin and he has been treated for a longer duration of time and the patient lands up in CKD, either we have to decrease the dose of sitagliptin or vildagliptin or we can shift the patient to linagliptin. Is that clear? The next question in hormones. Combined oral contraceptive pills act by all of the following mechanisms except inhibit implantation by bringing changes in the uterus, inhibit ovulation, make cervical mucus thick and hostile, increase gonadotropin secretion. See guys, the oral contraceptive pills, how it is going to produce the action? See guys, what are the different steps in terms of pregnancy? What are the different steps in case of pregnancy in terms of implantation and also the fertilization? First, there is going to be ovulation. Then it is going to move into the fallopian tubes. The ovarian is going to move into the fallopian tubes. There is going to be fertilization. Fertilization, how it occurs? Before where the sperm entry occurs. There is going to be fertilization. Followed by fertilization, there is going to be implantation. And followed that, there is going to be development into a full stage of pregnancy. Contraceptive pills is going to inhibit every individual step of this fertilization and implantation steps, guys. The first one, the oral contraceptive pills is going to inhibit ovulation, the first step. It prevents ovulation. The second step, it is going to cause cervical mucus thickening. If the cervical mucus is getting thickened, it is going to cause inhibition of sperm entry, the next step in the inhibition process. Cervical mucus thickening tend to inhibit sperm entry. The next one, oral contraceptive pills prevents fertilization, and oral contraceptive pills also prevents the implantation by producing changes in the endometrium. It prevents implantation of the fertilized ovum too. So all these 4 different steps is going to be inhibited. It blocks ovulation, it causes cervical mucus thickening, it prevents fertilization and also prevents implantation. Again, moving back to the question again. Combined oral contraceptive pills act by all of the following mechanisms except inhibit implantation by bringing changes in the uterus, yes. Inhibit ovulation, yes. Make cervical mucus thick and hostile, yeah, which prevents the sperm from gaining entry into the uterus. Increase gonadotropin secretion, it is not going to be seen, and that is why this is the answer for this question. Is that clear? Moving on to the next question in hormones. A 28-year-old female with Graves' disease, it is based on thyroid, the question is based on thyroid, was taking medication for hyperthyroidism during pregnancy. She delivered a child with congenital anomaly aplasia cutis congenita. It's direct, guys. Most likely drug implicated for this teratogenic effect is. They would have directly asked which of the following drugs tend to cause aplasia cutis, right? So, but they have to make every question to clinical scenario, right? So that's why they have given everything. So now, most likely drug implicated for this teratogenic effect is carbimazole, levothyroxine, methylthiouracil, leothyronine. Please note that one of the most important set of drugs, that is thioamides. We have 2 different drugs which is included in thioamides, and those drugs includes propylthiouracil and methimazole or carbimazole. Thioamides are set of drugs which can be used in treatment of hyperthyroidism. It inhibits organification and coupling, right? It inhibits organification and coupling. We have 2 sets of drugs. One is called as propylthiouracil. The other one is methimazole or carbimazole. The major difference between these 2 is propylthiouracil is safer in pregnancy. This drug is teratogenic. And at the same time, propylthiouracil is less potent, whereas methimazole and carbimazole are more potent agent. They are 10 times more potent than propylthiouracil. So even if we don't use it in terms of pregnancy, especially in first trimester. Why is it? Because it tends to produce teratogenicity. And what are the different teratogenic effects which can be seen? One is aplasia cutis. Aplasia cutis can be seen. There is going to be fetal goiter too. Aplasia cutis, fetal goiter. These 2 are the classical teratogenic effect which is seen with methimazole and carbimazole if it is given in first trimester alone. When it is given in first trimester. That's why, what is the drug of choice in terms of pregnancy? If a patient is pregnant, what is the drug of choice? If she is in first trimester, better opt for propylthiouracil. If she is in second or third trimester, better opt for methimazole or carbimazole. Methimazole or carbimazole. This is the treatment of choice in terms of pregnancy wise. Pregnant women with hyperthyroidism. So here, from this question, a 28-year-old female, Graves' disease, hyperthyroidism, aplasia cutis congenita. Most likely drug implicated for this teratogenic effect is what? Carbimazole is the answer for this question. Levothyroxine, no, it is a drug which can be used for hypothyroidism. Liothyronine, no, it is also a drug which can be used for hypothyroidism. That's it about questions which has been asked from hormones, guys. Moving on to the next and important area, central nervous system. In central nervous system, the first question is, which of the following statements is true about disulfiram? Which of the following statements is true regarding disulfiram? It acts as an anti-craving agent for alcohol. If person consumes alcohol after taking disulfiram, he feels drowsy with flushing of face and breathing difficulty. We'll explain about that. And then we'll go towards the options now. Whenever a patient is being administered alcohol, it is going to be converted to aldehyde. It is going to be converted to aldehyde. This conversion to aldehyde is based on two different enzyme complexes. The first one is via alcohol dehydrogenase, and the second one is via microsomal enzymes, especially the oxidase enzymes. Microsomal enzyme, that is oxidase enzyme, is going to be involved in the conversion of alcohol to aldehyde. Further conversion of aldehyde to acid is going to be occurring with the help of an enzyme, and that is aldehyde dehydrogenase. So the concept behind usage of this drug, disulfiram, is disulfiram tend to inhibit this aldehyde dehydrogenase enzyme. What is the function behind it? The function behind this, the usage of this drug behind this is, if you give disulfiram to a patient, this aldehyde dehydrogenase is going to be inhibited. Now, after taking disulfiram, if the patient takes up alcohol, all the alcohol will be converted to what? It will be converted to aldehyde, and the further conversion of alcohol to acid, aldehyde to acid, will not occur. Now, what happens? Aldehyde tend to accumulate in the body. Aldehyde tend to accumulate in the body, which might produce certain symptoms like drowsiness, pain, nausea, vomiting, abdominal pain, flushing. All these symptoms is going to be there. Even certain patients might land up in hypertension too. So these are the different symptoms which can be seen if a patient is on disulfiram, he or she takes alcohol. After some period of time, what happens? There is going to be constant withdrawal of alcohol. The patient will be slowly coming out of this alcohol dependence. But the most important point which we have to understand is, the patient, we have to make sure that we have to get consent from the patient. We can't give it without the knowledge of the patient. We need high motivation for starting this disulfiram therapy. The patient must be coming up to you and they have to say that, sir, please do something. I have to stop this alcoholism. I have to get out of this alcoholism. Only with this amount of high motivation, not only from the patients, also from their relatives, we can opt for this disulfiram. But nowadays, disulfiram is going to be replaced by many different newer drugs like naltrexone. We have acamprostate. Many different drugs are there which can be safer alternatives. We also have a long-acting benzodiazepine. Chlordiazepoxide also can be given. But if it is a methanol poisoning, we have to opt for an alcohol dehydrogenase enzyme inhibitor. Why? Because we don't want it to be converted to the aldehyde format itself. We don't want formaldehyde to be accumulated. So alcohol dehydrogenase is going to be inhibited by fomepizole. Alcohol dehydrogenase is going to be inhibited by fomepizole. Fomepizole is going to be useful in the treatment of methanol poisoning and ethylene glycol poisoning. Methanol and ethylene glycol poisoning, we can use this fomepizole, right? So coming back to this question again, which of the following statements is true regarding disulfiram? It acts as an anti-craving agent for alcohol. No, it is just going to prevent the patient from, just increases the drug addiction. It just increases the accumulation of aldehyde. If a person consumes alcohol after taking disulfiram, he feels drowsy with flushing of face and breathing difficulty. It appears like the true. We'll go with the other options first. It can be used in a person who has negligible motivation to quit alcohol. No, it can't be done. We need motivation from the patients itself. Even after cessation of therapy, its effects persist for many days. No, it is not so. It might be there for 3 or 4 days, but compared to all the different steps which we have seen, compared to option D, option B is going to be the most important answer for this question. If a person consumes alcohol after taking disulfiram, the patient might feel drowsy with flushing of face and breathing difficulty can be seen. Coming towards the next question. A patient of severe depression was treated with tricyclic antidepressants. The patient has landed up in TCA. The patient improved and discharged after 4 weeks. After 4 weeks, the patient has been discharged. What is the major concern of the practitioner after discharge of this patient? Suicidal risk due to overdose of drug, cardiac arrhythmia and seizure as toxic effects, need to measure plasma levels by therapeutic drug monitoring, sedation due to the drug. See guys, tricyclic antidepressants, it has got certain classical feature guys. Tricyclic antidepressants, consider this is your presynaptic terminal and we have the postsynaptic terminal. From the presynaptic terminal, we have a vesicles which contains 5-HT because this is a serotonergic neuron. Once the impulse comes down from the brain, there is going to be release of this 5-HT into the synapse. So there is going to be release of all the 5-HT into the synapse. We have 5-HT in the synapse. This 5-HT is going to interact with its own receptor on the post-synaptic terminal. It is going to interact with its own receptor. Once the interaction is happening, for as long as the interaction is happening, the patient will be devoid of any depression symptoms. But once the vacuum pump which is there on the presynaptic terminal, what is that vacuum pump guys? We have a vacuum pump on the presynaptic terminal. This vacuum pump is called as SERT, S-E-R-T, serotonin transporter. So what is the function of this serotonin transporter? This 5-HT which is bounded with this receptor is going to be reuptook into the presynaptic terminal via this serotonin transport, right? So this is a vacuum pump. This process is called as reuptake. So 5-HT is going to bind with this receptor. Because of the opening of the presynaptic receptor, there is going to be influx of this 5-HT and it gains entry into the presynaptic terminal. So because of it, the interaction is going to be blocked off. If the interaction is going to get blocked off, the further responses is not going to be seen and the patient will land up in depression. If there is overactivity of serotonin transporter, there is going to be very minimal interaction of serotonin with this receptor. So the patient lands up in depression. So what's the treatment of choice? So again, we have to block the serotonin transporter. TCAs tend to block the serotonin transporter. Not only that, it also tend to block certain other receptors too. And what are those? It tends to block alpha-1 receptors, muscarinic M1 receptors and histaminergic H1 receptors too. Because of the blockade of alpha-1, M1 and H1 receptors, the patient lands up in adverse effects. Alpha-1 receptor blockade tend to produce postural hypotension. M1 receptor blockade tend to produce anticholinergic adverse effects, especially we have constipation. H1 receptor blockade tend to produce sedation. These are the classical adverse effects which can be seen when a patient is on treatment with tricyclic antidepressants. One more important area is there, and that is tricyclic antidepressants also carries an equal risk of low therapeutic index or a narrow therapeutic index drug. Because of its narrow therapeutic index, it needs therapeutic drug monitoring to be done. Therapeutic drug monitoring needs to be done for this patient. This is the most important point regarding the tricyclic antidepressants. Why we need the therapeutic drug monitoring is the patient might land up in toxicity symptoms too. The patient might land up in toxicity symptoms of tricyclic antidepressants, and what are those? It can be remembered with the mnemonic 3 T's. 3 C's. Tricyclic antidepressants. 3 C's can be used to remember the toxicity symptoms of tricyclic antidepressants. First C is for the patient might land up in coma or convulsions or cardiotoxicity and acidosis. Cardiotoxicity is primarily due to the acidosis which is seen. So 3 C's are the mnemonic to remember tricyclic antidepressants. 3 C's are the toxicity symptoms which can be seen with those. So again, coming back to the question, these are the important features of tricyclic antidepressants, guys. Coming back to the question again, which is the major concern for the practitioner after discharge of the patient? So once the patient is getting discharged, what is the concern for the medical practitioner? What he might be expecting in the few days? So suicidal risk for overdose, no, it is not going to be seen. It is going to be seen only when the patient is of lesser age, less than 25 years of age, the patient might be there. Cardiac arrhythmia and seizure as toxic effects, yes, it can be seen. Need to measure plasma levels by therapeutic drug monitoring, yes, it can be seen. Sedation due to the drug, yes, it can be seen. But the major concern is cardiac arrhythmia and seizures, right? If the question was asked like, how can we prevent the adverse effects following the discharge of the patient? If the question was, what is the next step to be taken to prevent the toxicity symptoms to occur? We can opt for option C, the need for therapeutic drug monitoring. But the question is not that. We don't have a concern to do therapeutic drug monitoring. It's our duty, right? So the concern is the adverse effects which the patients might develop. So cardiac arrhythmia and seizures as toxic effects is the most important concern of any patient who has been treated with tricyclic antidepressant and the patient has been discharged out. Again, we have the first question which was asked from alcohol, this is disulfiram. The next question we have tricyclic antidepressants, antidepressant agents. Third question, a patient presented with absent seizures. Which of the following drugs are useful for this patient? We have given options: carbamazepine, ethosuximide, gabapentin, valproate. Which drugs can be used for absent seizures? Please remember that absent seizures is primarily because of calcium channels. So the treatment for absent seizures is we always opt for a calcium channel blocker. What are the different calcium channel blockers? We have ethosuximide, we have valproate. Also, we can opt for lamotrigine too, because lamotrigine tend to have three different blockades. It tend to block NMDA receptors, sodium channel blockers and calcium channel blockers. So we have three different drugs which can be used for this condition, but out of these three, which drug is currently the drug of choice? If you want to select one out of this, we have to opt for ethosuximide, guys. Please remember this. If we want to select one out of this, we have to opt for ethosuximide, which is currently the drug of choice for absent seizures. Why is it? Because majority of the books tend to say that there is a confusion between valproate and ethosuximide, but we have to compare it based on two different concepts: efficacy and safety, right? As per efficacy is concerned, the valproate is equi-efficacious with ethosuximide. The efficacy is going to be equal. But as per safety is concerned, as per the adverse effect profile is concerned, the ethosuximide is little bit higher than valproate, because valproate tend to produce severe ADR like hyperammonemia, hepatotoxicity, there is going to be weight gain, induction of diabetes mellitus. Lots of different ADRs are associated with valproate, even alopecia. Many different ADRs are there for valproate. So compared to that, ethosuximide is going to be lesser, having lesser ADR. So you have to select ethosuximide if we want to select one out of them. But if we don't have ethosuximide as an option, we can opt for valproate, right? So here, what are the different drugs which can be used as? Ethosuximide is there in the options, valproate is there in the options. Ethosuximide and valproate, 2 and 4. Option B is the answer for this question. Option B is the answer for this question. Moving on to the next question. Antidepressant associated with least sexual adverse effects. Least sexual adverse effects: fluoxetine, mirtazapine, imipramine, venlafaxine. So you have to know an important point, guys. The important difference between all these things is fluoxetine is an SSRI, selective serotonin reuptake inhibitor, fluoxetine. Mirtazapine is an NASA drug, noradrenergic specific serotonergic antidepressant agent. Imipramine is a tricyclic antidepressant, whereas venlafaxine is a serotonin norepinephrine reuptake inhibitor. You have to know an important concept that we have the selective serotonin reuptake inhibitors. Serotonin reuptake is going to be inhibited. If that is inhibited, there is going to be more 5-HT in the synapse. There is going to be more 5-HT in the synapse. If there is more 5-HT in the synapse, it might act with many different receptors on the postsynaptic terminal. If it is acting with 5-HT1 receptor, it is going to be useful in treatment of depression. But if it is acting at 5-HT2 receptors, it is going to be involved in sexual adverse effects. 5-HT2 receptors is going to be involved in sexual adverse effects like anorgasmia, or the patient might going to be loss of libido. These are the different sexual adverse effects which can be seen, especially with selective serotonin reuptake inhibitors. In order to decrease all these responses, we have come up with the next set of drugs, SNRI, noradrenergic specific serotonergic antidepressant. All the other drugs are derivatives of this SSRIs. So we have produced it in terms of its least sexual side effect producing. So we have to note here is SSRI tend to produce maximum sexual side effect, followed by the tricyclic antidepressants, and followed by SNRI, serotonin norepinephrine reuptake inhibitors. But out of all these three, mirtazapine tend to produce least effect on the sexual side effect, and that is the answer for this question. That is the answer for this question. Why is it? Because this is a noradrenergic and specific serotonergic antidepressant. It was designed especially to prevent its interaction with the 5-HT2 receptors. It is actually, it has got additional 5-HT2 blocker and 5-HT3 blocker activity too. And because of its H1 blockade 2, because of 5-HT2 blockade, there is least sexual side effects. Because of 5-HT3 blockade, it has got anti-emetic effect too. Emesis is one of the most common ADR associated with SSRI, guys. Because of H1 receptor blockade, it might also produce sedation. These are the classical features of mirtazapine, guys. Mirtazapine is one of the most important drug which can be used to augment the effect of SSRIs. If a patient has been treated with antidepressants and if a patient is not responding properly, to augment the effect of the antidepressant, we can opt for mirtazapine. Move on to the next question. A psychotropic drug inhibiting the reuptake of serotonin is likely to cause which of the following adverse effects? Selective serotonin reuptake inhibitor or any drug which is going to increase the serotonin levels in the synapse. Which of the following areas can be seen? That's the question. Visual disturbance, constipation, dry mouth, sexual disturbance. See, visual disturbances, constipation, dry mouth, all these are anticholinergic adverse effects. Anticholinergic adverse effects are seen only with M1 receptor blockade. Right? Whereas sexual dysfunction is seen whenever there is more amount of 5-HT in the synapse when it is interacting with 5-HT2 receptors. The question is clear, inhibiting the reuptake of serotonin, which means which of the following ADR is associated with more serotonin levels? Sexual dysfunction is the answer for this question. We have just now seen it before. Sexual dysfunction is the answer for this question, guys. Moving on to the next question. A patient is on long-term anticonvulsant therapy. There is a progressive contractility of visual field. The likely anti-epileptic drug responsible for this adverse effect is. Please note that it's a recurrently most commonly asked question in many different enzymes. We have the drug that is V-gabapentin. It's the most direct question. V-gabapentin. VI is for visual disturbances. VI is for visual disturbances. GABA is for GABA. TR is for GABA transaminase. IN is for inhibitory. This drug is a GABA transaminase inhibitory agent. GABA transaminase inhibitory drug, V-gabapentin. V-gabapentin has been here. This patient has been treated on long term with anticonvulsant therapy, right? So, what might be the condition in which the patient might have been administered V-gabapentin? Tuberous sclerosis. So, for which condition do we use this V-gabapentin? When it is used for long term therapy, it can be used for infantile spasms with tuberous sclerosis. For infantile spasm with tuberous sclerosis, V-gabapentin is the drug of choice. For infantile spasms, the drug of choice is ACTH. Adrenocorticotropic hormone is the drug of choice for infantile spasms. When it is associated with tuberous sclerosis, we can opt for V-gabapentin. This is the basic concepts about this V-gabapentin. So, from this, what is the answer for this question, guys? V-gabapentin is the answer. Is that clear? Moving on to the next question. A 30-year-old patient was started on lithium carbonate for bipolar disorder. Lithium is being started for bipolar disorder. The nurse gave instructions on adverse effects of therapy. The patient should report back if the following features are seen: palpitations, chest pain, raised BP, sedation, constipation, vomiting, tinnitus, diarrhea, ataxia, fever, skin rash, bradycardia. So, before going further, we need to know about the adverse effects of lithium. Lithium is most important topic. We can expect at least one question, or we can also expect two questions in INI-CET, guys. Most important drug. You have to remember many important points based on that. So, lithium, what are the different adverse effects associated with that? Adverse effects can be classified into many different areas, guys. Overall, I have classified them into the first one. Lithium causes shaking of something in the body. It increases something, it decreases something, and it flattens something. It causes shaking of something, increases, decreases, and it flattens certain things in the body. Shaking of hand and body. Hand means it is going to be associated with the tremor. Body means the patient might be having seizures. Tremor can be seen, what type of tremors? Fine tremors or coarse tremors? At low toxicity, at low level of low plasma concentration of lithium, we can expect fine tremors. At higher concentrations, we can expect coarse tremors too. What are the different things which is going to be increased? CLU, CLU and W is going to be increased because of lithium. C is for calcium, there is going to be hypercalcemia. L is for leukocytosis. The patient might be suffering from leukocytosis. Increased urine output. That is, the patient might be having nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. The drug of choice for the treatment of nephrogenic diabetes insipidus due to lithium is amiloride. The drug of choice for lithium induced nephrogenic diabetes insipidus is amiloride. The next one, W, is for weight gain. Lithium induces weight gain too. Now, what are the different things which is going to be decreased because of lithium? Decreased, the first thing, thyroid will be decreased and hair will be decreased. Thyroid and hair, the concept is, thyroid, the patient might be having hypothyroidism, but hypothyroidism is not the common one because of lithium. The patient might be having just benign or non-tender, just thyroid enlargement is going to be seen. Just thyroid enlargement is going to be seen, benign and non-tender enlargement will be seen. Rarely the patients might develop hypothyroidism. Very rarely the patient might develop hypothyroidism, but most commonly it is not going to be seen. Only benign non-tender thyroid enlargement is going to be associated with lithium. We have to take TFT and also the the body weight, basic body weight levels. We have to calculate all the different values, especially targeting these areas. Hair loss will be seen. The patient will be having alopecia. The patient will be having alopecia, and it flattens something. It is going to flatten T waves. T waves can be flattened or it might be inverted. Flattening, or the T waves might be inverted too. T waves may be inverted or T waves may be flattened because of lithium. And also, it can also be associated with development of acne. Lithium induced acne is also an important area. There might be vasculitis. Vasculitis associated with lithium too, which can be seen. And most importantly, it might aggravate psoriasis. When lithium is given for psoriasis patients, it might cause aggravation of it. These are the different areas associated with lithium, guys. You have to remember all these things. Very, very important area as per your INI-CET is concerned. So from these areas, we can clearly explain that the most common one which can be seen is tinnitus, diarrhea and ataxia. The patient has to report back if a patient has got these three different symptoms. These are the important adverse effects. This is the answer for this question too. Now, moving on to the next one. For plasma level monitoring, lithium estimation is done at what time? You have to know that lithium estimation has to be done, that is therapeutic drug monitoring has to be done after 12 hours after last dose. After last dose, which means if the patient has taken at night 8 o'clock or 9 o'clock, the patient has taken the drug, the lithium last dose he has taken. The next day morning exactly at 8 o'clock or 9 o'clock, we have to monitor, we have to do therapeutic drug monitoring, and we have to check the levels, we have to estimate the levels of lithium. This is the answer for this question, guys. The next one. A patient presented to emergency with head injury and pelvic fractures, and the CT scan suggested raised intracranial tension, that is raised intracranial pressure. Patient was given morphine and the respiratory difficulty followed. What is the most likely cause of respiratory problems? Morphine, as we have already explained previously, morphine shouldn't be given in case of respiratory depression, especially in patients with increased intracranial tension. Morphine should not be administered. Why? Because morphine tend to produce respiratory depression and carbon dioxide retention due to opioid use. Because of more amount of carbon dioxide retention, the patient will be having respiratory depression. So morphine is contraindicated. To say opioids are contraindicated in case of head injury. An important point, opioids are contraindicated in head injury. Opioids can be administered in terms of MI, myocardial infarction. We can administer opioids, but for head injury, opioids are contraindicated, guys. These are the different questions which have been asked previously in central nervous system. Moving on to the next one, cardiovascular system. A patient was on metoprolol therapy. Which is a beta blocker, by the way, for hypertension. He was also administered verapamil. Verapamil is a calcium channel blocker. Which of the following is likely to happen with above combination therapy? See, guys, beta blockers tend to produce negative inotropy, negative chronotropy and negative dromotropic effect. It tend to decrease cardiac contraction, it decreases heart rate, and it might also decrease the atrioventricular conduction velocity too. Calcium channel blockers can be classified into two major types. One is dihydropyridines and the other one is non-dihydropyridines. Dihydropyridines and non-dihydropyridines. Dihydropyridines includes your dipin agents, amlodipine, nicardipine, felodipine, this set of drugs. Whereas non-dihydropyridines includes verapamil and diltiazem. and also we have the newer etripamil. Etripamil can be given as nasal spray, guys. So depends verapamil, diltiazem, etripamil. What is the major difference between these two? Calcium is necessary for the contraction of any type of muscle, whether it might be skeletal or smooth muscle or cardiac muscle. We need calcium for that. The depends is going to have more activity on the vessels. The vascular calcium channel blockade property is more than cardiac calcium channel blockade property. On the contrary, the verapamil, diltiazem and etripamil, those are non-dihydropyridine calcium channel blockers, tend to have cardiac calcium channel blockade property more than vascular calcium channel blockade property. That is also one of the reasons why depends are actually contraindicated in angina too. Contraindicated in angina. Why is it? Because if the vascular effect is more than cardiac effect, it tends to produce vasodilatation. If there is vasodilatation, there is going to be decrease in blood pressure. Decreased blood pressure leads on to reflex or rebound hypertension. The BP is going to rise up. If the BP rises up, again there is going to be an issue. It is going to further worsen angina. So that's the reason why the depends are contraindicated in angina. Is that clear? Whereas verapamil, diltiazem and etripamil can be given in terms of angina, but we have to monitor one important concept. As it is having more cardiac activity, it also tends to produce negative chronotropy, dronotropy and inotropy. If we give beta blocker and non-dihydropyridine together, there might be most important ADR, that is bradycardia with AV block. Bradycardia is nothing but negative chronotropy, AV block is nothing but negative dromotropic effect. So beta blocker and non-dihydropyridine calcium channel blocker should never be given together. It's an important rule for. That's the basis behind this particular question, guys. Now moving on to the next question. All of the following drugs are indicated in the treatment of NSTEMI except. NSTEMI, what are the different drugs which can be used, and what are the different drugs which can be used in STEMI? ST elevated myocardial infarction. If the patient reports, if the patient has got a chest pain and if he or she is reporting to the hospital within 2 hours, and you take up the ECG, the patient complains of chest pain, the patient reports to the hospital less than 2 hours, and if the patient has got, the patient might be having ST elevated myocardial infarction or non-ST elevated myocardial infarction. If it is less than 2 hours, even if it is STEMI or even if it is NSTEMI, we have to opt for percutaneous intervention and coronary artery bypass. CABG can be done. But if a patient presents of more than 2 hours duration, and if the patient is having STEMI or NSTEMI, we have to opt for, again, if it is STEMI, we can opt for percutaneous intervention or even CABG, or we can opt for thrombolysis. But for NSTEMI, we can opt for aspirin, clopidogrel, atorvastatin. That is, we have to give an antiplatelet agent, we have to give 2 antiplatelet agents, and we can also opt for an anti-hyperlipidemic agent. So by administering these drugs, we can prevent the patient from progressing to the next stage of cardiac pain. But here, thrombolytics should not be administered in NSTEMI. If the patient is on NSTEMI, thrombolysis should not be given. We can opt for aspirin, clopidogrel and atorvastatin. So that's what the question is going to be targeted more on. All of the following drugs are indicated in treatment of NSTEMI except clopidogrel can be given, aspirin can be given, prasugrel can be given. Streptokinase being a thrombolytic, it should not be given in terms of NSTEMI, and that is the answer for this question, guys. Moving on to the next area, blood, GIT and renal systems. Which of the following drugs should be avoided in a patient on rosuvastatin therapy? Which of the following drugs is going to have an interaction with rosuvastatin therapy? Rosuvastatin therapy is nothing but these drugs are metabolized. These drugs are metabolized by cytochrome P enzymes, guys. These drugs are metabolized by cytochrome P enzymes, rosuvastatin. So any drug which is going to inhibit the cytochrome P enzymes is going to increase, is going to cause accumulation. I have a microsomal enzyme inhibitor. This drug is going to inhibit this metabolism, and because of it, what is going to happen? And because of it, there is going to be increased rosuvastatin levels in the body. Because of accumulation of statins, the patients might land up in myopathy or rhabdomyolysis. Because of extreme amount of rhabdomyolysis, the patient might also land up in acute renal failure too. Especially this rhabdomyolysis is a common ADR which is associated with statins, guys. So microsomal enzyme inhibitor should not be administered in terms of a patient who is on a statin therapy, especially here the patient is on rosuvastatin therapy. Out of this, which drug is a microsomal enzyme inhibitor? I hope you remember that drugs, guys. Microsomal enzyme inhibitors, what are those drugs? It can be remembered with the mnemonic Queen, Priyanka Chopra, mixes vodka with ice. Mnemonic to remember the microsomal enzyme inhibitors. Queen is for quinine or quinidine. P is for protease inhibitors. C is for cimetidine, chloramphenicol. Mixes is for macrolides. V is for valproate. O is for oxetin. Oxetin is your fluoxetine, which is an SSRI, and also we have omeprazole. Oxetin and omeprazole. D is for DEC, diethyl carbamazine. G is for grapefruit juice. And A is for azoles. Your ketoconazole, itraconazole, voriconazole, all the azole groups. ICE is for isoniazid. ICE is for isoniazid. So these are different microsomal enzyme inhibitors which we have. Out of this, which drug is going to be the answer for this question, guys? We have seen that option A is nothing but clarithromycin. So we all know clarithromycin. If the drug name is ending with mycin, we'll be having lots of confusion, guys. If the drug name contains romycin in its name, it is a macrolide. If the drug name contains romycin, it is a macrolide. So this is the answer for this question, guys. This is the answer for this question. Clarithromycin should not be administered in a patient who is on a statin therapy. Moving on to the next question. Which of the following drug can be used as an antidote for fibrinolytic overdose? Ethamycillate, altiplase, antioxidant alpha, and epsilon aminocaproic acid. See, guys, the fibrinolytics, the concept is we need conversion of plasminogen to plasmin. Plasmin is the one which is going to convert fibrin to degraded products. Fibrin is converted to degraded products by plasmin. So we need more amount of the activation of plasminogen to plasmin, which is going to be involved in more amount of this conversion, guys, which is going to stimulate the conversion of plasminogen to plasmin. Those drugs are called as fibrinolytic agents. Fibrinolytic agents, which includes your T-place drugs and kinase drugs. T-place drugs and kinase drugs. T-place means tissue plasminogen activator agent. TPA analog agents are T-place agents. And also we have kinase. What are those T-place agents? We have altiplase, retiplase, and tenecteplase. Kinase agents include streptokinase and urokinase. On the contrary, we have certain drugs which might inhibit the activation of plasminogen. Drugs which might cause blockade or inhibition of conversion of plasminogen to plasmin, and those drugs are antifibrinolytic agents. Those drugs are antifibrinolytic agents, and those includes epsilon aminocaproic acid, we have tranexamic acid, and aprotenin. Out of all these different agents, antifibrinolytics can be used in terms of fibrinolytic overdose. Out of EACA and tranexamic acid, epsilon aminocaproic acid can be used as the drug of choice for fibrinolytic overdose. Drug of choice for fibrinolytic overdose. Is that clear? So based on these options which we have, which of the following drugs can be used as an antidote for fibrinolytic overdose? Epsilon aminocaproic acid is the answer for this question. Whereas we know what is altiplase, we have antioxidant alpha. Antioxidant alpha is the antidote for factor 10A inhibitor, direct factor 10A inhibitors. 10A inhibitors are nothing but Savan drugs, right? 10A banned drugs. What are those 10A banned drugs? Savan drugs are apixaban, rivaroxaban, all these drugs. In terms of poisoning, we can use this antidote for factor 10A, that is antioxidant alpha. Moving on to the next question. Dicumarol antagonizes the action of vitamin K by. Dicumarol is nothing but it's a coumarin derivative. Coumarin derivative like warfarin. So what is the mechanism of action of warfarin, guys? What is the mechanism of action of warfarin? Warfarin tend to produce inhibition of vitamin K epoxide reductase enzyme. vitamin K epoxide reductase enzyme is going to be inhibited. Because of the inhibition of vitamin K epoxide reductase enzyme, there is going to be inhibition of reduction of vitamin K. So thereby vitamin K dependent clotting factors is going to be inhibited. Vitamin K dependent clotting factor synthesis like factors 2, 7, 9 and 10 is going to be inhibited. And also not only that, we also have protein C and S. Protein C and S synthesis also is going to be inhibited. So warfarin tend to inhibit factor 2, 7, 9, 10. So thereby it is going to produce anticoagulation. Because the clotting factors are inhibited, it tend to produce anticoagulation. Whereas protein C and S is getting inhibited, so the patients might land up in coagulation. The contrary, yeah. The opposite also is going to be true with warfarin. Not only warfarin, even dicumorol also has this ADR. There might be induction of new coagulation. Clotting might be there, the clotting risk might be there whenever a patient is started on warfarin. So how can we prevent this coagulation from developing? How can we prevent this coagulation from developing? I can prevent it by giving heparin bridging. Whenever a patient is started on warfarin, we should not continue the patient especially on a single dose of warfarin. We have to give heparin along with warfarin for a period of 5 to 7 days in order to cover up the coagulation which can be seen. Later on, the vitamin K dependent clotting factors getting inhibited, right? Those effects is going to overtake and anticoagulation process will start occurring. Is that clear? So this drug, your warfarin, not only that, your coumarin derivatives tend to be an inhibitor of vitamin K epoxide reductase. What type of inhibition is this? This drug is a competitive inhibition. This is a competitive inhibition, and that is the answer for this question. It's a competitive inhibitor of vitamin K epoxide reductase enzyme. That's it about your blood, GIT and renal system, the question which was asked in last year. Among antibiotics, a 15-year-old female presented with sore throat and was given antibiotic by a local practitioner. After 2 days, she developed rash on the body. Which is the likely drug responsible for this? The rash, they have given an image. So which of the following drugs tend to produce rash? It's a direct question, guys. Very easier one. Amoxicillin is the answer for this question. Amoxicillin is a penicillin derivative. The patient has developed penicillin allergy reactions. Prednisolone is a steroid. Which can be used for the treatment of this kind of rashes. Even fexofenadine also can be used for the treatment of rashes. H1 antihistaminic agent. It's a H1 antihistaminic agent, a derivative of terfenadine. Salbutamol is a beta-2 agonistic agent. It is also not going to be causing any types of rashes. So here amoxicillin is the drug which has the tendency to produce a rash, and that is the answer for this question. Now to the next one. A patient presented with an episode of seizure. And CT scan revealed the presence of calcified cysts in brain with no evidence of hydrocephalus. A diagnosis of neurocysticercosis was made. Which of the following statements regarding treatment of this condition is correct? So here the patient is having neurocysticercosis. So what is the drug of choice in treatment of neurocysticercosis, guys? Albendazole is the drug of choice. Albendazole is the drug of choice. We can opt for antiparasitic agent, but before administering this antiparasitic agent, whenever you administer albendazole to these patients, there might be production of hyperinflammatory syndrome. It might be associated with hyperinflammatory syndrome. In order to prevent the inflammation from developing, we have to make sure that the patient is administered steroids first. We have to administer steroids followed by we can go for this albendazole, because whenever the albendazole is going to be given, it is going to target these worms, and whenever this worms is going to be targeted, it gets exposed to the immune system and there is going to be hyperinflammatory responses. So once the inflammatory response starts, it will be difficult to stop it. That's the reason why we give a prophylactic dose of steroids before administering this antiparasitic agent. So here what is the answer for this question, guys? For neurocysticercosis, only antiparasitic should be given. No, it is not the right option. We have to give a steroid before that. Antiparasitic drug should be given, and after the completion of course steroid should be given. No, steroid should be started first followed by antiparasitic agents. Yeah, this is the right option to be given. This is the answer for this question. Only anti-epileptic drug should be given. No, that is also not the right option. So we have to opt for steroids followed by an antiparasitic agent. What if this patient is not been diagnosed as neurocysticercosis, and if the patient presents with seizure or any other conditions, we have to opt for an anti-epileptic. Only anti-epileptic drug should be given. But as this patient has been diagnosed with neurocysticercosis, the cause of the epilepsy is the worms which is there. So that's why we opt for the steroid followed by antiparasitic drug therapy. Is that clear? Next question, which of match the following antimicrobial drug with the microorganism that are used against? We can start from the thing which we already know, guys. We have vancomycin. Vancomycin, everyone knows that, right? Vancomycin is currently the drug of choice for MRSA, right? Vancomycin is the drug of choice for MRSA. What's the drug of choice for VRSA? VRSA can be either pulmonary or extrapulmonary VRSA. Pulmonary VRSA or extrapulmonary VRSA. For pulmonary VRSA, we can opt for linezolid. For extrapulmonary, we can opt for daptomycin. For extrapulmonary, we can opt for daptomycin because daptomycin tend to be broken down by the surfactants in your lungs, so it cannot be given for pulmonary VRSA. For extrapulmonary VRSA, we can opt for daptomycin. Is that clear? Now, so vancomycin, the treatment is vancomycin goes for MRSA. Metronidazole goes for bacteroids because we know that's the one of the commonest drug which can be used. Meropenem is currently the drug of choice for the treatment of Klebsiella pneumoniae. Meropenem is the drug of choice. Carbapenem derivatives is the drug of choice for Klebsiella pneumoniae because normally for Klebsiella pneumoniae we have certain sets of drugs to be administered, but most of the Klebsiella pneumoniae are extended spectrum beta lactamase producing agents, ESBL producing bacteria nowadays. So any patient who have been diagnosed with Klebsiella pneumoniae in India has to be administered meropenem. So the other one is ceftriaxone. Currently this is the drug of choice for Haemophilus influenzae. Is that clear? This is the answer for this match the following question. So drug of choice is an important area as per INICET is concerned, guys. The next question, which of the following is a second line anti-tubercular agent? Again, this is a direct question directly asked from the classification of anti-TB drugs. What are the first line drugs? What are the first line drugs? We have HRZE. These are your first line agents. Isoniazid, rifampicin, pyrazinamide and ethambutol are the first line agents. We have to say reserve first line agents. We also have streptomycin. Streptomycin is not a direct first line agent, it's a reserved drug, reserve first line agent. If a patient is not responding properly, we can opt for the streptomycin, but usually we don't administer streptomycin for all the patients. We give only isoniazid, rifampicin, pyrazinamide and ethambutol. Whereas the second line drugs, we have a list of agents which includes ethionamide. Ethionamide is the answer for this question. Ethionamide is the answer for this question. Vancomycin, no, it is not used for tuberculosis, and acyclovir is an antiviral drug. It is also not used for tuberculosis. Streptomycin is a first line agent. Streptomycin is a first line agent. It is not a second line agent. Is that clear? So the next one, all of the following are bactericidal drugs, bactericidal agents against Mycobacterium except. Please note that the HRZE, these are the first line agents, right? We have just now seen it. All the first line agents are bactericidal in nature. Even S also is bactericidal in nature except ethambutol. Except ethambutol, all the first line agents are bactericidal agents. Is that clear? What about the second line agents? Among the second line agents, the thiacetazone is a drug which is going to be a bacteristatic in nature. Kanamycin is nothing but belongs to streptomycin group, aminoglycoside. Aminoglycoside is a acidal agent. Aminoglycoside is a bactericidal agent. Rifampicin also is a bactericidal agent, we have just now seen it. Isoniazid is also a bactericidal agent, we have just now seen. Thiacetazone is one of the older drugs, it has been seen as bacteristatic agent. Currently we don't use it, but this is a bacteristatic agent against Mycobacterium. Which of the following is the only drug that decreases mortality in a patient with severe COVID-19 on respiratory support? So guys, COVID-19 induced death might be of two different reasons. It might be the respiratory induced death or it might be cardiovascular induced death. The cardiovascular induced death is nothing but a post-COVID complication, or it might be a COVID induced complication, coagulopathy. Because of that coagulopathy, the patient might be landing up in myocardial infarction and the patient might die because of that. But COVID-19 per se is going to affect your respiratory system, so the respiratory induced death is the most common cause, is one of the most common cause of death among COVID-19 infections. So among the respiratory infections, what should be the drug of choice? The inflammation syndrome. We have to take control of the multi-system inflammatory syndrome, and this inflammatory syndrome can be controlled only with steroids. Only with steroids. Steroids are the drugs which are currently the only drug which might decrease mortality. But at the same time, recently on the surge, because of the surge of the black fungus mucormycosis, there might be an increase in mortality rate. It might be because of steroids use, say unwashed steroids use on patients who were known diabetic or who were already on immunosuppression. Because of these different reasons, there might be development of mucormycosis, but steroids per se tend to decrease mortality in COVID-19. So we need judicial use of steroids in COVID-19 individuals. So this is the answer for this question. Dexamethasone is the answer for this question. Hydroxychloroquine is currently not recommended for COVID-19 because of adverse drug reactions and also lack of efficacy. Favipiravir is a drug which can be used only for mild infections. It is not used for moderate or severe cases. Remdesivir can be used for severe cases and also for moderate cases, but it is not going to decrease mortality. Mortality is going to be decreased only with steroids, guys. The next question, which of the following drug has no role in the management of severe COVID-19? Just now we have seen that. No role in the management of severe COVID-19 pneumonia. Remdesivir can be used, dexamethasone can be used, low molecular weight heparin can be used, favipiravir is used only in cases of mild COVID-19 infections, and that is the answer for this question. Favipiravir is the answer for this question, clear? The next one, a resident doctor developed needle prick injury while taking blood sample of HIV positive symptomatic patient. Which of the following regimen is best for post-exposure prophylaxis? So for PEP, currently the regimen of choice is we opt for tenofovir plus lamivudine. We can opt for tenofovir with lamivudine. This is currently the treatment of choice for post-exposure prophylaxis. It can be given for a period of 4 weeks. But as we don't have this option here, we can opt for this zidovudine given along with lamivudine or also given along with indinavir. We can opt for these 3 drugs when given in combination in treatment of. Now moving on to the next question. Which of the following antifungal drugs possess additional anti-inflammatory and antipruritic activity? Additional anti-inflammatory and antipruritic activity. Please note that sertaconazole is the drug which is an antifungal drug with additional antipruritic and anti-inflammatory activity. Luliconazole can be given via topical route. It is currently been recommended for many different conditions, but compared to luliconazole, sertaconazole has got additional and a better anti-inflammatory antipruritic activity. These are the different questions which were asked from antibiotics in last year INICET and AIIMS exams. Which of the following drugs can cause the side effect given in the picture? So this side effect here we can see the flagellate dermatitis. This side effect is nothing but flagellate dermatitis. Flagellate dermatitis is a classical ADR of one important drug, and that drug also tend to produce additional pulmonary fibrosis too. It also tend to produce additional pulmonary fibrosis too. And these 2 different areas are associated with bleomycin. These 2 areas are associated with bleomycin, and bleomycin is the answer for this question. What are the other drugs which tend to produce pulmonary fibrosis? The other drugs which tend to produce pulmonary fibrosis can be remembered with the mnemonic Nice Babe. NI is for nitrofurantoin. C is for cyclophosphamide. B is for busulfan. A is for amiodarone. B is for bleomycin. And E is for ergot and its derivatives. Ergot and its derivatives. Please also note important points. We have certain ergot and its derivatives. We have certain other ergot and its derivatives. All the ergot and its derivatives has got certain common areas to be associated with. Ergot and its derivatives tend to produce fibrosis, that is pulmonary. It might be pleuropulmonary or cardiopluropulmonary fibrosis. Also there might be associated vasospasm. The vessels might be constricted to up to the level that there might be a vasospasm, and because of it the patient might develop gangrene. What are the different ergot and ergot derivatives? Ergot drugs is easy to find out, guys. The name itself will contain ergot, ergotamine, ergotoxin or ergonovin. Ergot drugs will be having that name. What about ergot derivatives? Ergot derivatives includes bromocriptine, methysergide, cabergolide, pergolide. All these 4 different drugs are ergot derivative agents because these are derived from ergot alkaloids. So these drugs also tend to produce the same ADRs. Fibrosis and vasospasm can be seen. Or ergot derived drugs, if it tend to produce vasoconstriction, if it tend to produce vasospasm or gangrene, the drug of choice in treatment of that is, the drug of choice for the treatment of ergot induced vasospasm is sodium nitroprusside. Sodium nitroprusside is the drug of choice in treatment of ergot induced vasoconstriction. Is that clear? So the answer for this question is, as we've already explained, this is flagellate dermatitis, which is seen with bleomycin, guys. The next drug, a female with unilateral breast cancer. A female with unilateral breast cancer is on tamoxifen therapy. Which of the following adverse event is associated with the use of tamoxifen? Unilateral breast cancer associated with tamoxifen. You have to know an important, this question is better to be included as hormones, because mostly it is coming under the selective estrogen receptor modulators. So we are going to talk about the important features of selective estrogen receptor modulators. What are the different drugs which we have, guys? SERMs, we have clomiphene, bazadoxifene, we have raloxifene, tamoxifen, torimifene, doloxifene, or meloxifene. These are the different selective estrogen receptor modulators. Clomiphene, we all know it can be used for the treatment of anovulatory infertility. It can be used for anovulatory infertility. Ormeloxifene is nothing but your centroman. What about this bazadoxifene, raloxifene? This is where the questions are currently being asked, guys. Bazadoxifene, raloxifene, tamoxifen, torimifene, and doloxifene. Please remember this, bazadoxifene and raloxifene, it's a mnemonic to remember, guys. Please remember that these are B and R drugs. Tamoxifen, torimifene, and doloxifene, remember T and D drugs, right? So based on this, we are going to write up a mnemonic to remember the actions of individual drugs. B and R, T and D. B and R tend to produce good effect on certain areas in the body. It tend to produce bad effect on certain areas in the body. BBLU, BBLU, and BBL. BBLU for the B and R and BBL for TED, which is nothing but B is for in terms of breast, it has got good effect. In bone, it has got good effects. In liver, it has got good effects. And in uterus, it has got good effects. Whereas in case of blood or in case of clot, it has got bad effect. Whereas T and D again is going to be breast, bone, liver, here clot, and uterus. This is nothing but I used to call it as a visual mnemonic, guys. So if you just keep on looking at that image is going to be stored up in your brain, and that is going to be useful, and that's going to fetch a lot of marks in your exams. Which means bazadoxifene and raloxifene can be used for the treatment of CA breast, can be used for osteoporosis, tend to decrease the lipid levels, the good cholesterol levels is going to be increased, and it can be used for CA endometrium too. But it has got bad effect on clot. There might be thromboembolism which is associated with bazadoxifene and raloxifene. T and D, tamoxifen, torimifene, and doloxifene can be used for CA breast. Currently, tamoxifen is the drug of choice for CA breast. Bone osteoporosis can be used for osteoporosis. It might increase the good cholesterol levels and decrease the bad cholesterol levels. At the same time, the patient might land up in thromboembolism and the patient might land up in CA endometrium. So CA uterus is an ADR of tamoxifen, torimifene, and also for doloxifene. And this is how we are going to find out the answer for this question. So for this question, unilateral breast cancer, the patient is on tamoxifen therapy. Which of the following adverse effect is associated with the use of tamoxifen? The answer is direct, guys. The answer is endometrial carcinoma. Endometrial carcinoma is the answer for this question. Is that clear? We are the next one. Drug of choice in treatment of hairy cell leukemia is, no need to worry, it's a direct question. Hairy cell leukemia, the drug of choice is cladribine. Hairy cell leukemia, the drug of choice is cladribine. Right? We have certain miscellaneous questions which has been asked. Match the following drugs with their antidote. Heparin, the antidote is protamine. Protamine is the antidote for heparin. We all know that ethylene glycol, we know that, let's talk about the known ones. Ethylene glycol, what is the antidote? Fomepizole is the antidote for that. Valproate, carnitine is the antidote for valproate because the valproate is associated with hyperammonemia, an important ADR. Hyperammonemia is an important ADR of valproate for which we can use carnitine as a treatment. And hydrofluoric acid, we can opt for calcium gluconate. For hydrofluoric acid, we can opt for calcium gluconate because to counteract the electrolyte disturbances which has been seen with those. Is that clear? Now the next question. A patient suffering from infective endocarditis. A patient suffering from infective endocarditis was given high doses of penicillin and gentamicin. Which of the following statements is correct regarding these drugs? TDM should be done for both drugs as these have narrow therapeutic index. TDM should be done for penicillin as it can cause severe anaphylaxis. TDM should be done for gentamicin as it has got narrow therapeutic index. TDM is not required for any of the drugs as both have wide therapeutic index. We all know that gentamicin is an aminoglycoside agent. Gentamicin is an aminoglycoside agent. Gentamicin is an aminoglycoside agent, and this drug tends to be a narrow therapeutic index agent, and that's why we need therapeutic drug monitoring needs to be done for that. Which means we have wiped out the option D. Therapeutic drug monitoring is not required for any of the drugs, both have high therapeutic index, is not the right option for that. Now here again also therapeutic drug monitoring should be done only for penicillin as it causes severe anaphylaxis, also is not going to be there because we need to do TDM for gentamicin. Now comes the query whether we have to do it for both the drugs or we have to do only for gentamicin. Please note that the penicillin group of agents. Penicillins, yes, they tend to produce anaphylaxis. But therapeutic drug monitoring is not for monitoring the adverse effects, it is for monitoring the toxicity symptoms, it's for making the anaphylaxis is not going to be predicted up by the therapeutic drug monitoring. If a patient is allergic to a particular drug, he will develop allergy even at low dose or even at high doses. Therapeutic drug monitoring is to monitor the levels of drug, that is not going to be the reason for that. Penicillin is just going to produce an allergic reaction, but penicillin when given at low doses, tend to have a wide therapeutic index. But when the same penicillin is given at high doses, it tends to have a narrow therapeutic index. Penicillins. So as these drugs also tend to be a narrow therapeutic index, especially penicillin when given at high doses, TDM needs to be done for penicillin when given at high doses. For normal doses, no need to worry, but when given at high doses, we have to go for therapeutic drug monitoring. So that is what the answer for this question is. Therapeutic drug monitoring should be done for both drugs as both has got narrow therapeutic index. Here if the question is just penicillin and gentamicin, the option would be go for gentamicin. But if the question is for both gentamicin and high dose penicillin, so we have to opt for therapeutic drug monitoring. Is that clear? Now the next question, a new fixed dose combination of two drugs, codeine and dextromethorphan, both for suppressing the cough is launched. What should be your appropriate decision regarding this fixed dose combination? See guys, codeine is actually an opioid agent. Codeine is actually an opioid. It has been approved for the treatment of cough, but it has got addictive potential. And respiratory depression. It might produce addiction and respiratory depression. To counteract that, what we do is we derive one more drug called as dextromethorphan. Dextromethorphan was actually derived from codeine. From codeine we derived methorphan, and from methorphan we derived dextromethorphan. This dextromethorphan also is an opioid, but this drug has got less addiction or respiratory depression. The combination itself is not going to be useful because why should we give a drug which tend to produce addiction, and why should we give other drug which was derived from the same drug and given along with that just because it is producing less addiction? The concept itself is irrational, and that's why this we should not prescribe this drug because as this combination is irrational is the answer for this question. Is that clear? So these are the different questions which we have faced in the last year INI-CET and also for AIIMS exam, guys. I wish you all the very best for your coming INI-CET exams. So please prepare well and just come out with flying colors. Best wishes, buddies. Thank you so much.